So, Dr. Scholz, today we're answering questions that we received during our 2022 Moyad and Scholz mid-year update. We had a great conference, and if people would like to view that, it's still on our channel. But we wanted to answer some of the questions that were remaining. I know our helpline team reached out, but we'd like to hear your thoughts. So, does radiation for a different cancer preclude, radiation for prostate cancer?
Much, much less than it did in the past. There are certain circumstances where it can. Turns out that radiation is very geographically or regionally specific now. The area of the body that's been previously treated, say someone had lymph node radiation for a lymphoma in their abdomen or their neck or something of that nature, that doesn't get in the way of prostate radiation at all. The type of radiation that might get in the way is if someone had radiation for something in the pelvic region and you were trying to radiate the prostate, the question would be whether you could re-radiate the same area. In the old days, we said, no, you can never do that, and previous radiation would preclude any further radiation. But now, in this modern era, the radiation is getting so pinpoint that they are able to, in many cases, re-radiate a previously radiated area. So the general answer to that question is that previous radiation for some other cancer, in all likelihood, will not get in the way of prostate cancer radiation.
Is there such a thing as radioresistance in prostate cancer?
Yes. The way that radiation kills cancer is dose-related. And so one could say that if you can just give a big enough dose, you can kill anything with radiation, and therefore there is no radioresistance. But the problem is that you're radiating a cancer in the background of normal tissue. And normal tissue actually tolerates radiation better than cancer does, but there is a limit. And so there are times when the limits of the surrounding tissues preclude a high enough dosage of radiation to kill certain variants of cancer. That would be called a radioresistant cancer, where you because of the circumstances, you can't give a big enough dose to get rid of all of it. We don't really have ways to know in advance of whose prostate cancer might be more or less radioresistant than another. But there is quite a bit of variety. There are certain types of cancers that are more radioresistant. Fortunately, modern radiation has developed to the point where, because of its accuracy, they can give much bigger doses than what was previously available. So the problem of radioresistance, that is, not getting all the cancer, has been greatly reduced. So we don't see what we call in-field failures the way we did, say, 15, 20 years ago. This is one reason that the surgeons always like to talk about doing surgery first so you can do radiation later if you need another treatment. And that was a pretty good argument 15, 20 years ago, because there were a lot of patients who were having radiation and then the cancer would come back in the radiated field. You couldn't do more radiation, and then you had to have a difficult surgery. That problem is very rare in this modern era. With modern radiation, it has become so efficacious that the doses are high enough to eliminate the cancer almost universally. So the problem with people not getting cured with radiation in this modern era is not a tumor that was able to survive the radiation. The problem is a tumor that had metastasized and there was a spot somewhere else in the body that just didn't get radiation. That's the relapse in this modern era.
So I know we've talked about what the PSA should look like after radiation and the follow-up in other videos, but just because of that answer, I'd like to cover it here. How do you know whether you're radioresistant after you've had treatment? What does that timeline look like of PSA decline?
Interpreting PSAs after radiation is a little tricky for several reasons. We won't go into great detail, but one is that sometimes the radiation can cause some inflammation in the prostate, which is a bump. The PSA goes up. Sometimes the prostate gland survives the radiation better than the prostate cancer, and so prostate glands make some PSA. So a person may have a low level of PSA after having radiation, and they could be completely cured. Interpretation of PSA after radiation requires some skill and experience. PSA is very, very useful for monitoring people, but it's not perfect. The pattern, of course, of steadily rising PSAs that go on over a period of time is pretty conclusive evidence that you're dealing with a recurrent cancer. But PSAs that are remaining low and stable, or bouncing in a range and not going up in a sequential fashion, usually mean that the cancer is under control.
What would that time frame look like?
Well, it varies. The time to PSA nadir. So let's say someone starts with a PSA of 10 before radiation. It may take up to 2 years for the PSA to reach its final nadir, which ideally should be maybe less than a half a point, depending on the different types of radiation. So yes, people do need to be patient, and we're not expecting PSAs to plummet rapidly to zero after radiation. The radiation poisons the cancer cells, and then they slowly die over a period of 2 years. This was demonstrated in biopsy studies where men had prostate radiation, and they were biopsied 6, 12, 18, and 24 months after the radiation, and they could see viable prostate cancer cells 18 months, sometimes 24 months after. On subsequent biopsies, the cancer cells disappeared. So the cancer cells aren't dying overnight when you radiate the prostate. They're slowly dying over a period of 1 to 2 years.
Does it make sense in any case that after a patient receives radiation, their PSA may be bouncing around, they want to make sure they got all of it? Would a PSMA scan make sense?
PSMA PET scans are answering a lot of questions now, and in a situation where there's uncertainty about whether cancer is back, whether it's in the prostate or somewhere else in the body, PSMA PET scans can bring a lot of clarity. The fact that we know that cancer can continue to survive in the prostate for 1 to 2 years suggests that PSMA PET scans are still going to light up in the prostate. So you might not get a clear answer in that regard. But in terms of what's really important, whether the cancer is spread, PSMA PET scans are fantastic, because if there's nothing, no metastatic spots lighting up anywhere else in the body, then that's very comforting and reassuring that the cancer has not spread.
So in a different scenario, we've talked a lot about PSMA. How often are you seeing PSMA have false positives?
Not very often, but it's still new because how do you find out if someone has a false positive? Well, let's say a lymph node lights up, and then you undergo you suspect it might be a false positive, and you have some sort of a laparoscopic lymphadenectomy where they take the lymph node out, look at it under a microscope, and there certainly have been reports of false positives in that regard. One, of course, has to rely on the accuracy and the skill of the surgeon, that they remove the proper lymph node, but assuming that is all the case, it is possible to have false positives. Like any scan, you always have to interpret the context. Or if you're doing PSMA PET scans in people that don't have cancer, not that anyone would do that, and something lights up, then you're saying, wow, that's much more likely to be a false positive than a true positive. And then if you're dealing with someone that had a Gleason 10 and their PSA is 25 and something lights up, the chances of it being a false positive seem almost negligible. So you look at the context as well as the scan report. Just looking at scan reports without a context is a rather amateur way of interpreting scans. But experienced doctors know how to look at the context, and when it's a situation where you're not expecting to find something and you see it, then you start to wonder, could it be a false positive? And you have to ask yourself, based on the different treatment options, do we need to check this out further? But I'd say the incidence of, just a raw bottom line issue, the incidence of false positives across the board with PSMA PET scans is in the order of 1 to 2%. It's very rare.
How often do you see PSMA just miss? Like, what are the percentage rates based on the types of cancer do you see PSMA miss cancer?
Well, there's 2 types of misses. There's the 10% of men that have cancers that don't make PSMA. So that's missing all the cancer. And then there's the chances of people having either spots of cancer that are too small to be detected, or perhaps having variants where some of their cancer is making PSMA and other parts of the cancer are not. It's not a perfect scan. The studies that I've seen suggest that in men with high-risk prostate cancer, that about 20% of the time, when the scan shows no metastasis, there will be some metastasis. And in the men with intermediate risk cancer, that about 10% of the time, when there's no metastasis being shown, that there are metastases. So it's by no means a perfect scan, but it's certainly very useful information.
So let's just say you're in that 10%. Your PSMA scan came out clear. How do you monitor to know whether or not you were in that 10% or not?
As we've always dealt with the issue of getting PSAs every 3 months after the treatment for 2 years, another 3 years beyond that, we'll go every 6 months checking PSAs, and then annually for the rest of their lives. So that follow-up PSA monitoring remains the same.
Do you differentiate between regional, like lymph nodes, and oligometastatic disease?
I suppose so. Yeah, I mean, oligometastatic disease could mean regional lymph nodes, but they're really describing certain aspects of prostate cancer care that are a little bit different. So regional lymph nodes, let's just call them pelvic lymph nodes. When we think of pelvic lymph nodes, we think of a possibility of still curing the cancer. Even though the cancer is spread, we can aggressively pursue radiation and hormone therapy and chemotherapy, and we're going for a cure. When we think of oligometastatic disease, we're also going for a cure, but maybe not with the same conviction that we will actually cure it. It'll be perhaps a small percentage of people can be cured with oligometastatic disease. Oligometastatic includes not just pelvic lymph nodes, but a spot of cancer anywhere in the body. And it's only limited by the number of spots. So oligometastatic is 5 or fewer spots of metastatic disease. So it could be 5 bone mets and you have oligometastatic. So what the confusion would be, of course, is that you could have 5 lymph nodes in the pelvic region, and that's also technically oligometastatic. But the outlook would be better for the person that had regional pelvic lymph node disease than it would be for someone that had spots in other parts of the body.
Is Provenge effective in men with metastatic castrate-sensitive disease? Like, is this being studied at all?
Not that I know of, but I think it's pretty easy to assume that it is. The studies showing that it is effective against castrate-resistant disease, which is a more serious and dire and dangerous type of cancer, are unequivocal. There's randomized prospective double-blind trials showing better survival. So there's really no reason at all to believe that it wouldn't have at least as much impact, if not greater impact, against less serious cancer, i.e. a hormone-sensitive cancer. There's always the issue of hormone-sensitive cancers people can live a normal life expectancy and die of other causes. So it's hard to improve their survival by giving them any kind of treatment if we already know they're going to have a normal survival. But the anti-cancer efficacy of the treatment itself, I don't think should be called into doubt at all that it would be effective, yes.
So why isn't Provenge being studied in hormone-sensitive men?
It's just a financial reason. When the FDA stipulates the methodology for getting approval of a medication, they want to show men living longer with treatment compared to men not living as long without treatment. And these are very expensive trials where you have volunteers based on a coin flip. Some will get the treatment, some won't, and they'll watch them over a period of 3 to 6 years and see who lived longer. Difficult study to do, but if you pick hormone-sensitive patients whose survival is projected to be 10 to 30 years, the study won't be completed until we're all dead. And so it's just not financially practical to study it in the earlier stages when the FDA requires the endpoint of survival.
Thanks for watching. If you would like more information about prostate cancer, you can go ahead and subscribe to our YouTube channel. We come out with new prostate cancer videos every week. And go ahead and visit our website, PCRI.org. We have tons of information on prostate cancer that will help you.